And welcome to Healthline 3 on this Friday afternoon. We appreciate you watching us. My name is Jeff Binefor. We'll be here for the next 30 minutes. I have two guests with us today, Doctors Jonathan Henderson and Caitlyn Abney, a PA. Is it can't refer to you as a doctor then, right? Or can I? No. PA, Caitlyn Abney. All right. We appreciate both of them being with us. You guys are from Regional Urology, right?
Right.
So just to kind of get into this before we get started, if somebody needs your services and they need to contact you, how do they do that?
They can call 318-683-0411.
Okay.
That's our central switchboard.
Okay.
And we have offices in 7 locations, but that number will get you hooked up wherever you need to go.
Is the main campus on Burt Coons? Is that
It is.
considered to be the main campus?
It is. That's
All right.
where we have our laboratory, our surgery center, radiation center, and that's home base.
Okay, and what we're talking about today is hereditary cancer, correct?
That's right.
All right, if you have questions about this, if you've been affected, if you have family members that have been affected, you probably have some questions, and you can talk to the doctors directly and the PA. And you can do that several ways. You can do that online at ktbs.com. There's a box halfway down the right side of your screen. Type in the question there, or you can just give us a call. That's probably the easiest way. The number is 318-219-4569. We'll put you on the air. You can talk directly to the doctor and the PA. Trying to be correct here. Anyway, we'll be here for the next 30 minutes until 12:30. So as I said, what we're talking about today is hereditary cancer. So I guess explain to me exactly what you're talking about when you say that.
I think the main first point that needs to be made is we're not just talking about urological cancers.
We're not, okay.
Right? So, prostate cancer is the most common malignancy in men of all malignancies. It is a urological malignancy, but there's a link to breast cancer as well. So when a woman has breast cancer, in certain cases, the men related to her are at a higher risk for prostate cancer and vice versa.
Really?
Yep, and ovarian, pancreatic, liver, lung, and melanoma.
All right, and bladder cancer falls in there?
And bladder cancer and kidney cancer.
Okay, so I'm a bladder cancer survivor, and my dad he didn't have bladder cancer, he had prostate cancer. So would that have been something that's hereditary?
Could have been.
Yeah.
Could have been. What we look for is clusters within a family. There are certain keys that say, okay, this person should be tested. For example, if your father had an advanced prostate cancer and another member of your family related to him had an advanced prostate cancer, those two members trigger either of those people to be tested, and if they're positive, then all their offspring and siblings should be tested as well.
Okay, so Caitlyn, tell me the role the physician's assistant plays in doing the treatment and the diagnosis of this.
Well, with our current patients now, if a physician notices, within their family history that there are some red flags, then the physician can internally refer them to me to where we can kind of work out and see if they are a good candidate for testing, and then they would get tested, and then about 3 weeks later the results would come back, and we would go over those results.
When you say testing, tell me what do you do? What are you talking about?
It's a blood test. It's a blood trial.
Okay.
And the panel, it assesses about 28 genes that have been linked to, like he said, about 8 different cancers, not just urologic.
Okay, so you're talking about 28 genes that you guys are looking for, which is a lot. I mean, we don't want to get too technical here, but is there any one particular gene that causes more problems than the others?
Well, the BRCA gene is the first one that comes to mind.
Okay.
There's a BRCA1 and a BRCA2, and between the two of those, they make up about 70% of the mutations in familial prostate cancer. But as a lot of your audience knows, it's also breast cancer. That's the breast cancer gene. That's where the initials came from, and that was the first familial gene that was discovered about 20 years ago, and that just opened up the whole field of hereditary cancer.
So, Caitlyn, when you guys are looking at this, you've taken the blood draw and you're searching for, how does that show up? What do you see? What triggers your, oh, look, this guy's got a problem or this woman has a problem?
So what we're actually looking for is an abnormality of that gene. We all have the genes, every single one of us, but we're looking for an abnormality.
Okay.
When that abnormality is found, it's flagged and through the lab, and then we go from there and manage, treatment course, screening course from there based off of their particular abnormality in their gene.
And so when you say abnormality, is it just like a shape, a size, or what is it?
So it's a mutation in the gene.
It's proteins on the gene or something like, I'm just throwing, I remember that from like 7th grade biology class or something.
So really, we're made with tumor suppressive genes. That's how we are made. Our DNA has tumor suppressive genes. So naturally, our body knows to suppress abnormal growth of cells. And when there is a mutation found, it is more commonly found on those tumor suppressive genes. So that suppressive aspect is not there anymore. So you're at increased risk of cell proliferation and rapid growth, increasing your chance for cancers.
It's like a typographical error. The genes are basically instructions. And so if there's a gene that tells a cell, do not grow after age 30, and the word not gets omitted, then the cell sees the instructions do grow after age 30.
Interesting. And so, I mean, how much of this do you see in your practice? It's obviously something that's pretty widespread.
Yeah, it's a good question. You know, we started this back in the fall. It's a brand new field across the country, and Caitlyn led a little test for 1 month just to see how many of our patients are affected with the questionnaire. You want to
tell
share
us
that?
about it.
In a span of about 4 weeks, we tested everyone who walked in regional urology's front doors, and basically handed them.
You might have tested me.
Possibly. Handed them a questionnaire, basically, and asked them a multitude of questions about their family history and personal history regarding cancer. And based off their answers, we found that approximately 28% of just the people that walked into regional urology qualify for genetic testing based off of their personal and family history. So that's a pretty big number.
I was going to say that seems pretty high.
So, and
it's a little scary too, to be honest with you. Yeah.
And those are just those that qualify for testing. Not saying that they, have the gene and whatnot. They qualify for testing, so they have those red flags that sort of incline one to think maybe I should get tested.
Now, when I go out to your offices there, I mean, this is a busy place, regional urology. I mean, it is bustling. Their waiting room is always full. Is this something, this area, is this something, I mean, is this a high incidence of people coming for treatment on something like this? I mean, there's a lot of things you deal with, but
well, it is.
Is this near the top?
It is. Prostate cancer is one of the most common familial malignancies.
Okay.
I mean, if you take Caitlyn's information a step further, though, of those 28% that came in over those 4 weeks, 10 to 20% of them they were all candidates, but 10 to 20% would have tested positive for an abnormality. And you take that a step further, about 30 patients would have been positive for a mutation, undergone separate screening, and the statistics tell us that we would have, will we test those patients, 9 or 10 lives will be saved just through that 1 month of testing.
Wow, that's got to be kind of a good feeling.
Absolutely. Technology is wonderful, but you have to embrace it and use it.
All right, so how do we test them? How do they get it? They just come into the regional urology offices and say, I want to do this, or you tell them they should do it?
They're more than welcome. No, anyone. They do not have to be a current patient of ours right now being seen for something, or they can be. It can be any and all who have that inclination. Hey, I've had multiple same cancers on this side of my family. I've had a rare cancer in my family, such as ovarian or male breast cancer. People are diagnosed young in my family. I've had, a brother or sister, mom or dad that's diagnosed for colon cancer at age 30. They are more than welcome to come by and talk with us and get tested.
And it's just a blood draw.
It is a blood draw, yeah. And of course we would sit down with them and talk with them and learn about their family history first. And then, yes, proceed with the blood draw, and then 2 or 3 weeks later go over those results.
So let's say you come up with a patient that's positive, and they have cancer. I mean, what do you say to them? How do they react? How do you approach them and say, well, you have this weird mutated thing here. This is what we got to do. What's the normal reaction from folks?
Well, in good news, we've discovered this gene. I mean, we've discovered this gene that we're not telling them that they have cancer. We're telling them that, hey, you have an increased risk for this type of cancer, this type of cancer, and this type of cancer. It is in your best interest that you get screened earlier, more frequently, to prevent those.
But you're saying they're at risk. They have the potential to get it because of this gene.
Correct.
So is there a way to, eliminate that gene or eliminate that abnormality and say that thus eliminating the risk to get cancer, or is just something you got to follow?
Not yet.
Not yet.
Yeah, gene therapy is in the works right now.
It is, okay.
It is, and I mean, they're very active in prostate cancer, not just eliminating the gene, but the experts internationally estimate that within 5 years we'll have a gene vector that can actually be injected and cure a man of prostate cancer.
Really?
Yeah.
Wow. I mean, this is exciting stuff.
It is space age stuff.
So how is regional urology as a whole dealing with this? I mean, is this, you say it's pretty new, and you've just been dealing with it like, what, since last fall? Is that what you said?
Yeah, about 4 months, 3 months.
Wow. So how did you get into it? What made you, I mean, obviously there's some
question.
studies going on somewhere that you said we need to be doing this.
Well, you know, genetic testing came to urology about 5 years ago.
Okay.
And that's what really
not,
started
yeah,
it.
okay.
Not
Pretty
that long
new
ago.
then, yeah.
Yeah, and so what it started with was tests that would look at a man with prostate cancer and determine his risk, how aggressive the cancer was, what's the likelihood of it killing you or spreading or things like that, which we never knew before. And you know, one problem we've had historically with prostate cancer is over-treatment, because about 2/3 of prostate cancer is indolent. In other words, you don't have to even know it's there. It's never going to affect your life. But without these tools, we didn't know, you know, all prostate cancer looked the same to us. So anyway, we got genetic tests. We were able to break it down and find out who's at risk. That got us, you know, thinking genetics, and then we were in contact with the genetics companies and working with them as they discovered new products.
So just knowing that this exists, does that give you a better opportunity to do any kind of preventive stuff to prevent that from happening down the road?
Yeah, definitely.
It does,
Yeah,
okay.
definitely.
So like what would you do? What?
Dietary modifications, medication modifications, exercise, but also the screening, right? So you know, if a man has a significant risk of breast cancer, which is not common in men, but if we know that he's at risk, he gets a mammogram just like a lady does.
Really?
Yeah.
Okay.
If you have a genetic mutation that puts you at risk for colon cancer, instead of every 10 years having a colonoscopy, you have one every year.
Okay. So the key is to know that exists and then just continually do screening and testing.
Right. And lifestyle modifications.
Yeah.
Right. If you're at risk for colon cancer or breast cancer, you want a high fiber, low fat diet and increase your exercise.
Tell me about cherry Coke. Is that really bad? Because I drink that all the time. Is that bad?
Do you have leaded or unleaded?
No, this is full-fledged stuff. Yeah.
You got all the sugar in there. That's not real good.
That's bad, huh?
Yeah.
So how bad is sugar? Is that bad?
I mean, everything in moderation.
That's the
Thank
right
you, Ben
answer.
Franklin.
Yes. That's my outlook.
That's your outlook?
Yeah,
Okay.
everything in moderation.
All right, so what's the next step here? Where do we go with all of the stuff that you guys are doing? We're at this point now. It's pretty new. You're aware of it. You're taking certain steps, and then say it's space-age stuff. Where does it go from here?
Well, really, our main focus is benefiting the community. I mean, if we do find, you know, a male that is positive for a gene that puts his sister at risk for breast cancer, ovarian cancer, endometrial cancer, we can refer them to our local GYN, breast surgeons, and so helping outreach our hand not just to our patients but to everyone that we can possibly.
Talk to me a little bit more about that familial gene, and a guy has whatever prostate cancer and that puts someone at risk for breast cancer. That just seems odd to me. It seems like a disconnect in there somewhere. How does that work? I mean,
Caitlyn?
So there's certain genes that genetic specialists have linked to certain cancers. Just like we talked about the BRCA gene, that has been linked to breast cancer, ovarian cancer, prostate cancer, even pancreatic. So that's what that's what has been discovered, is that these certain abnormalities in the genes have been linked to certain cancers. And so if that's a positive gene within the family and it's known that it's in the family, then certain males and females know what cancers that they're at risk for, therefore knowing, you know, their screening protocol and management.
Okay.
So siblings share 50% of their genes.
okay.
Right? And so if a brother has it, then his sister's got a 50-50 chance of having it.
Okay.
The thing is, with BRCA, for example, this is what's called a DNA repair gene. All right, so your DNA, again, that's your genes. And our DNA is constantly breaking, but we have genes that fix it. When DNA breaks, that's how you get one of these mutations. So if your DNA repair gene is broken, then your body can't fix when your DNA breaks, and that's how the mutations form.
Okay.
And so that's why it can affect multiple organs, right? So
Okay.
you ask, well, the disconnect between the man and his sister. Well, it's a DNA repair gene. It repairs all the DNA in the body if it's breaking, or it doesn't repair it if it doesn't work right.
Okay. So folks at home that are watching us or listening to what you're saying, what they want to know is, how does this affect me? What do I need to do? I don't want to get cancer. You're talking about this stuff. I might be at risk. I want to find out, and I want to stop it from happening. That's what they want to know, right?
Right.
So what do you tell them when they come in there? Other than say, get a test. I mean, is there anything else to go beyond that?
There's lifestyle change. I mean, smoking.
Well, yeah. Okay.
Obesity.
Yeah.
There's multiple lifestyle things that
And
we can do.
Do people resist that though? They come in and they go, yeah, but I'm not gonna stop eating. I'm not gonna stop drinking. I'm not gonna stop smoking. Just give me a pill, right? That's what they want.
That's right.
It is, right? I mean,
Yeah, that's right.
seriously.
Americans don't want to change their, they don't want to be held accountable for their health.
Yeah. Well,
That's a sad fact.
I guess it is. I mean, I work out all the time, so I got at least that going for me. Although I've found out that all the working out and stuff that I've done is harmful in certain respects. But
Well, that's why we spend $3 trillion a year on healthcare in the U.S.
yeah. I want to know what I need to do. I mean, do I need to come in and get screened? I mean, I've had bladder cancer, so
that's
I'm beyond this now at this
Yeah.
point, right?
Yep.
So that's not beneficial
You're
to
good.
me. Yeah. I know I've got it. So I guess I have mutated genes. Is that the deal or no?
That's how all cancer starts, from mutated
Yeah.
genes.
Okay. All right. So,
And there's what's called a two-hit hypothesis.
Mhm.
In other words, it takes more than one mutation to create a cancer.
why does it come back? In other words, I've gone through the treatment. It went away once. It came back. It's gone again. But
That's a great question.
so why is okay?
Well,
Give me a great answer.
well, that's because every cell in your bladder has that same mutation.
Really?
Yeah,
Wow.
and so it's just sitting there waiting for that second hit, right?
Okay.
You already got one strike, and this is a two-strike ball game, and so if anything causes that second strike in your bladder, then that forms a cancer. Now, your immune system can go kill that cancer. Just like fighting off flu, the immune system also kills cancer. And that's the amazing fact that a lot of people don't want to really think about, is that all of us have a cancer form in our bodies routinely. But
Really?
the immune system kills it. We never know about it.
Wow, I didn't know that. I thought it was like a...
Not something to dwell on.
No, it isn't, but I guess we should be aware of it.
That's right. And that's why immune health is so important to prevent cancer as well.
All right, so let's say somebody comes in and we've gone beyond the testing. We've figured out they have these genes, but it's a little too late, I guess, maybe, and they've got a cancer now.
Right.
So let's say it's bladder cancer. I know what treatment I went through, but explain what you might do for folks to help them out.
With
Let's just say with any cancer, I guess, in general. What's the first step? We got to isolate what kind it is, and then figure out
find
the
out what
treatment.
kind it is, make sure it hasn't spread, determine, based on what kind it is, do we need to talk about surgery, radiation, chemotherapy? And again, advances are being made all the time. One recent one is the same kind of bladder cancer, same kind of cancer that occurs in bladder is called transitional cell, also can occur in the kidney or the tube from the kidney to the bladder. Historically, we've had to remove the entire organ, but one of the trials that we're involved with right now is injecting a little chemotherapy gel into the center of the kidney where the urine drains, sort of the sewer system there, and it kills the cancer just by that simple medication touching it. So, you know, there's hope. We've got lots of new things coming down the research pathways.
Is there a way to change heredity? Does that make any sense? You know what I'm saying? You have this potential. Is there a way to eliminate the potential?
Not yet.
Not yet.
Gene therapy has been successful in one form of muscular dystrophy.
Okay.
All right, so that's where, without getting too into the weeds, they basically take a virus and use it to go infect your body, but while it's there, it takes out the bad gene and puts in a good one.
Okay, but does it put in another bad gene while it's doing that, or?
Well, no, of course it has to be tested so that it doesn't do that. And a lot of people obviously are skeptical about that kind of thing because what if another mutation happens? So,
Right.
that is currently being done, though, in certain kinds of cancer. And so to your overall question, right, what do we do about it? I mean, that's the kind of thing that if we find that mutation in you in the future, we can actually get it out of your entire body.
Wow. That is amazing. That's
It
amazing
is.
stuff. So, Caitlyn, when you go to people and say, we want to test you for this and see if that exists, or are they resistant to that, or did they say, yeah, no problem, just go ahead and do it?
There is some hesitation. Some people don't want to know their they don't want to know fate, and then you have a spectrum. You have those that are very proactive, and they not only want to know for themselves, their offspring have a 50-50 chance. I mean, their children have a 50-50 chance of getting that gene. And so if they could tell, their daughter to start getting mammograms at age 25 or, earlier than the average general population, then yes, I do have a lot of people, very excited to do this.
Yeah, so should I go to my daughter now and say, look, you need to start getting tested earlier or sooner because I had this, it may increase your chances of having breast cancer or something?
I mean, given your family, we would have to get your family history and all of that, and then we would test you. And it's not only if you're positive, if you do have a positive gene, even if you have family history all throughout your family, her screening will be altered by that as well, not just the genetic testing.
So
as
it
well.
goes, okay.
It's a combination. If you're positive for the gene, then yes, her screening would be different than the average population. And then if you had increased family history, then her screening would also be increased as well.
See, I would think almost anybody would want to know this stuff and say, yeah, just draw the blood, do the test, and tell me what's going on, as opposed to, I guess they look at it like maybe it's a crystal ball or something, and witchcraft maybe. They don't want to look into it any further.
Well, it's rare enough that it's not approved by the insurance companies to pay for everybody across the board.
Yeah, that's a key, isn't it?
Right. So we're talking about 10%, say, of the people who meet criteria, and like we found in our office, the people who meet criteria is about close to 30%. But those are people pre-selected maybe to come to our office, so there's a little bias there. That's not going to apply to the general population. So you're talking 10% of 20%. It's not a lot of people. But there are people who want that information, even if they don't meet the criteria. In that situation, they can pay cash it.
Well, let's say you've done your testing and you've found that potential exists. Do you pass that on to, like, say, him, and then what do you do with that information? I mean, how do you utilize it? What do you do with it?
Oh, she doesn't need me.
Oh, she doesn't need you.
She takes care of it all.
Okay, well, why are you here?
That's a good question.
Just kidding. Just kidding. So, like, what you do is the key to this whole operation, huh?
So basically, the process, they come in, they get tested. If they test positive, we do discover a positive gene within their family, within that person, we would sit down and go over what that gene implied, what cancers they were at risk for, and then their particular personal screening protocol and management. Do they need to be seen by a gastroenterologist? Do they need to be screened for pancreatic cancer? Because not everyone needs to be screened for pancreatic cancer. But if they have this abnormal gene within themselves, we're helping them get screened not just in a urology, but a multitude. I mean, it's a whole thing.
So you would send them on to, like, some doctors maybe that aren't even in your practice.
Correct.
In other areas.
Correct.
Okay.
Yeah.
That's right.
Wow. I mean, are you guys like the only folks around here doing this, or are there other people
The
doing
breast
it?
surgeons and gynecologists, remember, this started with breast cancer,
okay.
so they're pretty attuned to it.
Okay.
But other than that,
Yeah. I mean, it seems pretty rare right now.
it is.
What you're
It's
doing.
new.
Yeah.
It's new. And Caitlyn will, I think one important thing she said is, people really want to know for their kids' sake more than their own.
Yeah.
But you sit down with them and you talk to them about what the risk is, and that's an important thing when we say increased risk.
Yeah.
Right? So the average population may be at risk maybe 1 in 1,000 for a melanoma, and increased risk could be 4 in 1,000.
Okay.
So the individual may say, okay, thanks, but no thanks. That doesn't worry me that much. I'm not going to worry about screening, or I'm not going to start using sunscreen or whatever. So risk is relative. Now, when we talk about increased risk, for colon cancer, say, if you have what's called Lynch syndrome, then you're talking about a very high risk, which necessitates at least annual screening.
Well, I mean, I know how I reacted when I was told that I had cancer, and it was like somebody hit me between the eyes with a hammer. You know, it's like, never going to happen to me.
Right.
So obviously it happens a lot. So part of the goal of all of this, I suppose, is to get people to the point where they don't have to feel like they get hit between the eyes with the hammer, right?
That's exactly right.
Instead of reactive.
Yeah.
Being a lot more proactive. I think that's our goal as well.
And you've done enough of this now, I suppose, where you're starting to get feedback from patients, I suppose. So what kind of, or are you? I mean, are they thankful that they've done these testings? Or they are?
Yeah, very. The peace of mind for the the preponderance are negative. And that's a positive negative, right? Because then they know I'm not at increased risk. And that's another important point, because just because you're not at an increased risk does not mean that you're not at risk.
Okay.
Right.
Okay.
So,
kind of explain the difference in what you're talking
right.
about.
So again, let's use colon cancer. If you have the normal risk for colon cancer, you get a colonoscopy every 10 years.
Okay.
Right? But if you're at increased risk, you get it annually. So if we test you and you don't have an increased risk, that does not mean you never need a colonoscopy again.
Okay.
Or mammograms. You know, if you're at increased risk, you have more frequent visits with your breast surgeon. But if you don't have that mutation, that doesn't mean, hey, I never need another mammogram. And that's one of the real important keys to get across.
All right. So all this testing you're doing is giving valuable information not only to the patient but the doctor, and then they kind of work together in tandem and figure out the best course of action. Yeah.
And it's important to remember that the majority of cancer is sporadic. We're looking at a very small percentage of the cancers that are passed down through families, inherited cancer. So if just for people to know, it's not just there's multiple cancers basically, and we're looking at about 5 to 10% of cancers which are inherited due to an abnormal gene, which what we're looking for.
So anybody with cancer in their family, should they be maybe coming to see you and getting some of the screening?
They absolutely can.
I mean, but should they be?
Well, I think just one person, no, but if their family anybody has another cancer, then they need to know if they fit criteria. They can go on the internet, look at the nccn.org, that's the National Comprehensive Cancer Network, and they'll explain what the criteria are. But to keep it simple, if more than one member in your immediate family has cancer, then you probably ought to sit down and either come talk to us or look online to see if you qualify. Okay.
How expensive is this for folks if they want to come in and do this? You said you talked about insurance companies not paying, and they could pay in cash. And I mean, can you give us some kind of ballpark number of what this might be? If they
usually less than $500.
Really?
Yeah. And I think the average out of pocket is around 58. 54, something like that.
Really?
Yeah.
See, I thought that it was going to be a lot more than that. I thought we were going to be into the couple 3,000 or something like that.
Now, there's one company that makes a test that we don't use because we don't use it, but they don't even bother with insurance, and they just say you're going to pay us $250 out of pocket.
Well, that seems like not much to pay to figure out.
That's right.
What your medical history or medical future might look like, right?
Well, and remember, the one thing we really haven't talked about is the precision aspect of this. I have prostate cancer patients. When we find these mutations, they tell me surgery's not your best option or radiation's not your best option. They guide how that individual receives care, which we don't know. The average patient that comes in for prostate cancer, we have a generic conversation. But if they have that mutation, or if it's an advanced prostate cancer, back to the BRCA gene, we know that the normal chemotherapies won't work for that patient. Well, if we didn't have that knowledge, this poor guy would be getting this toxic chemotherapy for no reason.
Right.
So it really makes it where it's a personalized medicine approach.
I mean, this is all really exciting to me. I mean, it's just like you said, it's outer space.
It's exciting to us.
How about, I mean, you're kind of on the forefront of this, right? What do you think about all
exciting.
of this?
It's exciting. Some things for people to know if you're having questions of whether you should get tested or not. Like we said earlier, multiple of the same cancers on the same side of the family, rare cancers such as ovarian cancer, male breast cancer, cancers in really young ages under the age of 50, metastatic prostate cancer, Those are things at home, if you're wondering, you know, should I call, should I get tested? Those are some red flags that you should come down and have a talk with us.
All right, very good. Interesting stuff, exciting stuff, really. Get tested, it'll help you. That's it for our Health Line today. Appreciate you being here.